So I'm going to ask Deborah if she would call the roll for us.
So please acknowledge by saying here or present. Senator Parker,
Here.
Representative Roberson, Dr. Baker, Senator Blackwell, Senator Boyd, Senator Bryan, Wendy Clemens, Representative Creekmore, Dr. Damon, Dr. Etney, Heather Garrett, Dr. Hogue, Dr. Johnson, here, Sarah Jones, Dr. Meredith, Representative McGee, Kate McMillan, Heidi Nelson, Linda Stewart, Representative Scoggin,
Present.
Julie Thornton, Jonathan Tritley,
Here.
John Robert Walker, and Dr. Weir. We have a quorum.
Great, and thank you again for getting up early. Like we talked last time, I think the advantage to doing this early is that we all have other roles that we have to serve in. So hopefully we can get our work completed this morning where we can continue what we need to do elsewhere this afternoon. So we're going to just jump into things this morning pretty quick. Lost my agenda. So of course, our first speaker this morning, slated for 8:15, is Dr. Lance Evans, our state superintendent. Like we did yesterday, what we did yesterday, Dr. Evans, is we gave some time for presentation, and then afterwards, we just took a few minutes for some question and answer. And so if you wouldn't mind, it worked pretty good to just be at the podium yesterday. If you don't mind standing for a little bit of time, we've got you, till just about just a little shy of 9 o'clock. So if you would just share with the group, your new role. I think everybody here knows you, but at the same time, there may be a few in the gallery or so who haven't met you. And then, and in particular, how in your new role you think you can help shed some light on the mental health issues that are before us. So good morning.
Yes, sir. I appreciate that very much. Thank you again for inviting us over and allowing me to come over and have a little bit of your time to talk about the issues that are associated with some of the mental health issues that we have in our state, especially in our K-12 world. But just a little bit about me. I've given this spiel so many times, I think I could do it in my sleep. But the short version is I am directly out of a school district. So what I would tell you is my perspective is hot off the press, if you will, from the standpoint of been living it, have seen the issues that we're experiencing in our school districts with our students, which also obviously bleeds over into our teachers, because they're the ones that are having to navigate the world, if you will, and at the same time provide a high quality education to all of our students. But in transitioning into this role, the mental health piece has been a piece that I have noticed in my previous role, the evolution of that, but from an evolutionary standpoint, in the wrong direction. It has been it's one of the most, in my opinion, one of the most needed areas that we have, I think, in the United States, but I'm speaking specifically to public education, because the issues that we find, lots of times the students, they bring that with them from home, and we're charged with taking care of the student, no matter what. I've always told our students, told the administrators that I work with, I'll be a student, I'll be your mom, your dad, your grandma, your granddad, whatever I got to be. to make sure you're successful. And we have to make sure that we're providing the support for all of our students to make sure that we're creating pathways of success with no dead ends for them, because we only have one shot. You know, we don't get to go back and redo their K-12 experience. So all that being said, I want to give you some information that will maybe shed a little light on some of the support services that MDE provides in this area, but also we've got a couple recommendations and then a couple, like one specific next step that we have moving forward to try to address this. But I do want to say, in the event I forget to say it at the end, this is an area that nationally we have issues, and specifically to the K-12 world. Every superintendent you talk to, every elementary principal, I promise you talk to, because that's where I've seen the biggest changes in our younger students. They would all echo that same sentiment, those struggles that are there. So, but the beauty of it is we are Mississippians and we do fix our own problems. So we definitely can do what we need to do to make sure we're giving our students what we need. But you know, MDE is an agency. Obviously, you all know this. We provide support services. We are a support organization for all of our school districts. We would not exist if it were not for the school districts in Mississippi. Provide professional development, technical assistance. Of course, we do have oversight of the academic piece as well as education, licensure, child nutrition, school finances, safe and orderly schools, and oversees somewhere in the neighborhood of about 1.5 billion federal dollars and somewhere in the neighborhood of about 2.9 billion state dollars that flow through our schools. I want to make sure that people in this room, I say this every time I get in a group of people, that money is not housed at MDE. It's not sitting there. It's simply a flow through. That we make sure that we're providing the support services for all of our school districts to meet the needs of our students. When we look at it from the standpoint of the role of school-based professional school counselors, MDE does employ one school-based professional counselor that provides support and training from the department through to the counselors in our schools. I'll tell you that currently school counselors are a very hot commodity, if you will. They are very difficult. They're in very limited supply, I guess would be the best way to put it. And we need to find ways to bolster that number of people, but also maybe find more creative ways to create licensing opportunities for those individuals, because we have people, it does require a master's degree to be a licensed school counselor. So absolutely do not want to diminish the expectations or anything like that. Please don't take me that way. But I think we have to be, this is 2024. And, you know, the world has evolved. And it's my granddaddy has a saying, it's the son, it is what it is. So it's kind of one of those deals to where we've got to that point where we have to do things differently to make sure we're meeting the needs of all of our students. Again, they provide the technical support to all of our school counselors. In the 23-24 school year, had somewhere in the neighborhood right around 1,498 professional school counselors who worked in the vast majority of the 825 public schools that we have in Mississippi. The sad thing, or the difficult thing, if you will, is that student to counselor ratio the number is very high. I mean, I'm a little embarrassed to even say the number, but it's an average of about 400 students to every one counselor. And that's tough. You know, you have some schools where and that's a thing to where it's availability, it's finances, it's, again, like I said, the pipeline of school counselors. But something that we have to remember, and those of you that maybe have never worked in the K-12 world, there is a difference in a school counselor and a mental health counselor, because they're not the same. Now, school counselors have training to equip them to help provide those services to a certain extent, but they are by no means a mental health counselor. And what happens is all too often they get projected or pushed into that role, and they take it with open arms and embrace it. But it is not their forte, if you will. That is, they're much more in line with the academic piece, the career piece. So that's why I was speaking so directly earlier to the fact that we have that ratio, but understand that ratio is not mental health counselors. It is school-based counselors. So that's a issue that, you know, we're addressing, and that's something I was talking with Dr. Murphy and licensure 3 days ago about, you know, what that looked like as far as what other states were doing nationally to help improve that pipeline of counselors. We've got a meeting next week, week after next, to talk about some of those ideas moving forward. So when you look at it, the primary piece for school-based counselors is the academic, the career, and the social emotional piece, which MDE has put a lot of work into pushing out the social emotional pieces since, I hate to even say the word COVID, but since the pandemic time. I will tell you that shed a light on a lot of things. Obviously that brought our country to its knees. And it also almost brought public education to its knees. But thank goodness in Mississippi, we saw the importance of getting back in school quicker, because I will tell you that had a huge impact on the recovery of our students. Because I have 2 children, and I had one that was old enough that it really wasn't that big of a deal, but I had a younger one, and I could see the impact, not being at school every day. It's different when they're not with their peers. Then we look at the MDE also has Office of Intervention Services, and in that office, they basically administer the SEL process. So, and you're looking at, the MTSS process, which basically MTSS stands for multi-tiered support systems, and you have this in your handout you can flip through later on. But it encompasses several components. It basically is a shared leadership piece. It encompasses a universal screener and progress monitoring piece. It also has a family and community partnerships aspect to it, as well as it has a process of data collection in order to help make better decisions, to improve student outcomes. That layered continuum of supports, because obviously it's not just one, it's not just one group or one agency that helps push that student through to make sure they're successful, as well as implementing the evidence-based curriculum and intervention services. And that piece encompasses, it has a specific academic piece and a specific behavior piece. So you can have a student in that system under just the behavioral piece, because one is going to affect the other. The behavior typically always affects the academic. Okay, you'll see that more often than not in schools. And also, MDE supports and encourages districts to implement a PBIS, Positive Behavior Intervention Services program, in their districts. And currently in Mississippi, we have 96 schools that are considered model PBIS schools. 2 of the schools in the district that I recently served employ that PBIS program. And it's later on, if you don't know much about that, I'll be more than happy to talk to you when we have some time. Just reach out and we'll talk about it, especially if you have maybe in your schools in your area, if they would like some support. That is part of my job. My role is to make sure you get that support for your schools in your area. Another piece is the MDE and their work with the AWARE grant, and that's Advancing Wellness and Resilience in Education. So basically what is taking place there is the MDE has worked with the Mississippi Department of Mental Health to coordinate to make sure that you're strengthening the access to mental health professionals in the schools. Because what happens in schools, in public schools, is you end up with most of those mental health professionals come from the outside in. So it's through contracts, through MOUs, through relationships, if you will. In some instances, actually, those mental health providers will come and practice, or provide services, if you will, in the school. But also at times, the school works with them if their offices are close, if they actually transport back and forth, just depending on the needs of the student. Another piece that the MDE is involved with is House Bill 1283, which is the Mississippi School Safety Act. It was in the 2019 legislative session. In this act, the House Bill 1283, it had a couple of requirements. And one of the requirements was associated with it was that the Mississippi Department of Mental Health create a pilot program for grades K through 5. And just a couple of quick pieces about that. They were tasked with creating a curriculum, if you will, field testing this curriculum. And again, it was in grades K through 5. And what we found was that pilot took place across 10 districts and 22 schools. And as an outcome of that, once the data comes back from that pilot, they will make recommendations as far as best practices and curriculum to implement that aspect in schools in Mississippi, making those recommendations. But still, you have to find a way to integrate that into the school day. Because like I said earlier, coming straight out of the school district into this position, I see that. Because you're in a world of academic, high stakes assessment, life, just trying to get let's be honest, life is hard. And teachers, they struggle, So it's being able to manage all this because they have those expectations on them and still provide what they need for their students. It's very difficult. We know it's very, very difficult process. The other piece, another couple pieces that MDE is associated with is the mental health and suicide prevention training that you see taking place in school districts. Every 2 years, MDE requires staff to be trained in suicide prevention. There's a process that we go through. It's an established curriculum that actually is developed with Mississippi Department of Mental Health in conjunction with them. School districts sign off that their employees have been trained every 2 years. Some do it more often. I recommend every year. But for sure, within the first 90 days of new employees being hired, they have to go through that training. So it's a yearly reporting process that districts report on to make sure that you have that, at least some basis of information to move forward to help someone. If you can recognize that issue, that an issue may exist. Another piece is looking at House Bill 231. And what that did is that took the tobacco education bill and added fentanyl and drug abuse prevention within it. Fentanyl has turned into a weapon of mass destruction, if you will, in our country. And Mississippi is not immune to this. And Mississippi public schools are definitely not immune to this. And I was so proud to see this piece of legislation come out because it's one of those things to where it's a shame we have to have laws at times to push people to make sure that we're doing the right thing, that we're holding people accountable. But I'll tell you, this drug alone has taken more lives and ruined more lives, ruined countless lives, but taking more lives than anything we've seen in the last 10, 15, 20 years. So it is a very daunting task to address. But the MDE is working with this task force. I believe, what is it? The 24-25 school year is when this has to be implemented. Just in closing, a couple of quick recommendations. And these are just best practices that MDE, through a conversation with our ELT team and other leadership, has put together. And some of them are very obvious, continue to train and review district suicide prevention and bullying plans. Because, the suicide piece is not just based on bullying. There's lots of other things. Like I said earlier, life happens, things happen. And we have to make sure that we're noticing it. So much of this can be helped. The issues can be decreased just by taking notice of changes in students' behavior and adults' behavior, but for sure changes in students' behavior. If a student has always been an A student and they're making bad, something's going on. Because typically if your behavior changes, you got to do some investigating. You got to figure out what's going on with that student. Again, continue to train your employees, but also train your short-term employees, like your subs, long-term subs. And in that training piece of suicide prevention, it's not just teachers. It is every employee. It's all your support people, custodians, office support people, people that work in food services, everybody, every human being bus drivers, everybody that you have. Because we all have a responsibility to ensure that we're taking care of our students. To make sure that districts are providing as much as they possibly can mental health support services for the adults in the school district. Because like I've said, I've alluded to this several times so far, it is very, very taxing. Because educators deal with their life at home, and then they deal with 30 lives in their classroom. And if you're depending on the grades you teach, it can be 150 lives over the course of a semester, if you will. the last recommendation is to make sure and maintain fidelity in the trainings. Because we know all too often, it's kind of like a drill. You know, if we don't take it serious, then we kind of do it and then it kind of falls off the quality of it. And then what happens is, well, we forgot it this time, so we'll do it next time. But we have to stay very vigilant in making sure that the training pieces are taken care of, that we are doing the training like we're supposed to be doing every year. And I can tell you, if a school district signs off that they have done the suicide prevention training and they have not, they get no support from me. You know, because this is something that is very, very, very important. Very important. Next steps. So one of the pieces that we're currently working on right now, and it goes back to one of the things I talked about earlier, as far as that seeing it before it happens type thing. In February, the MDE staff worked with a multi-state group with several other state agencies and went to Florida and looked at the Florida Harm Prevention and Threat Management Training Model. It's also called BTAM, is the name that people use for it. We have a 2-day meeting in August. It's August the 27th and 28th, where we're actually bringing in that leadership from Florida to speak with. I think we have about 40 individuals that are coming in, and the goal of that is to be able to put that system in Mississippi. So what will it do? Well, what it will do is, when you have a student who makes a threat, right now, in order, the people who make a determination as to whether that threat is credible or not are typically your school-based counselors, your administrators, maybe your school nurses. Well, obviously, the weight of that is very heavy. So you have to make a decision at that point in time: do I send this student for further evaluation? But I would tell you, it's probably almost 100% of the time that student gets sent for further evaluation. Which, what happens is, because of the lack of mental health support that we have, can equate to like 5 days that student is out of school trying to get this risk assessment. It happens. We don't have those people employed in our school district, which leads right into the chronic absenteeism issue that we're currently addressing as well. So looking at creating putting that system in Mississippi and then making it a mandate across the state of Mississippi, it will help. And not to go into belabor, because I know my time is up, but it will help. It's a system in which it's a team of people that help make those decisions. And it doesn't just deal with the student in the current situation that they're in, but it also looks at the entire student from a holistic standpoint, from a family, their behavior over the years. And it's a holistic process. I guess just the best way to put it, so that we can create in our schools the layers of support services for that student to make sure that they're getting what they need to be successful in life. That's all I have.
Well, thank you. And what I'll do, I've got just a couple of questions, and then, we'll open it up for some more discussion here. Little earlier in your discussion, you mentioned the School Safety Act of 2019, and how that had begun, and you were looking for outcomes. When will those outcomes be available? What date can we?
I don't have. I can get that date for you.
Okay.
But that is in coordination with Mississippi Department of Mental Health, so we can get that.
And then yeah, and
Hang on, I'm making a note right quick. I'm sorry for
the tie-in that you mentioned on the suicide, bullying, and prevention, that was appreciated. And then one other topic that we hit on yesterday, of course you weren't here for that, but we talked about how Marshall County is implementing a policy regarding their cell phones for the students as a pilot program. And we also went into some discussion about the changes that we've seen in young people and how their access to their phone and how they use their phones regularly, not just, for communication, but also getting notifications all the time of what's happening either on social media or or just the notifications we all get, how that can impact education. Have you, in your brief time, in your role, had any discussions or looked at any solutions we might have for the attention deficit that is created by the constant influence of cell phones upon, kids during the school day?
I have had conversations. I've had conversations with a couple of our senators, as well as a couple of our representatives, as well as Lieutenant Governor. Had a conversation with him about that. In the beginning, cell phones, it's unintended consequences is probably the best way I could describe this is they provide a service. They had a place at one point in time in school when we didn't have one-to-ones like we have now, because people would use them, obviously for a multitude of reasons instructionally. The problem then is you had the issue of, well, this kid has an iPhone, this one, right? We get into whole other issues that revolve back to potential mental health deals, bullying, because you don't have the same level of phone as someone else. But I'll tell you, over the years, it's the social media piece associated with the phone, because so many people, and this is adults as well, they live their life of whether they're happy or sad based on clicks and based on likes. And I am absolutely not, I am for anything that helps our students maintain what they need to make sure that during the school day, that they're getting what they need. I will tell you this, and looking at it, I don't really know where like the happy medium is, because I do think came in and you just said it's an all out just ban. Okay? Well, you may end up in pushback from a safety standpoint, as far as someone calling, if they see someone, just a thought, all that is a thought. But I do think we for sure, even if you take away a phone during the day, something that you got to always remember is we do have one-to-ones in every district in Mississippi. And you have to make sure that on your not mobile device, school, the security platform, right? That all these social media platforms are blocked. Because where I have been the last several years, we're a pretty worldly district. So we are very open to lots of things. But most of every social media platform, we had blocked. There was no value in it. There was no educational value in it. Now, some were. Twitter at times, because it's an informational thing. We had that there. It was being used. But most of your students are not like living on Facebook. They're living on TikTok and Instagram and, places like that. They do utilize Twitter, not as much as some of the others. But we have to remember, just because we stop it on the phone, kids are very resilient. You take away the phone, they're just going to use it on their device. So you have to make sure that those systems are blocked. And then, of course, there's workarounds that you have to work with. Like I said, they're very, very adults are very resilient. But I'm definitely not against any of that. I would just say that we would want to work to make sure that we do it in a way to where there is no unintended consequences to it. But there are a lot of districts. I'm giving you a long answer. There are a lot of districts that have actually passed policies. It's not just Marshall. There's a lot of districts that have passed policies that in place.
So do you know exactly what Marshall County is doing?
Well, I believe, are they not the one that actually has the bag, the pouch that they're putting them in? Am I correct? I think, and that way
That is correct.
I'm sure somebody has more information than I do, but that's to my understanding. That's a very rudimentary understanding of what to do.
And then we made some mention yesterday of, at the end, we talked about the desire to have someone who developed some interest in our kids.
I'm sorry, I can't, I'm sorry.
Yesterday, we talked about the need to find someone who can follow a child through school, understand who that child is. We went into some discussion about how if a teacher each year is evaluating the student that they see on the first day of school, they don't know who that child may have been psychologically the previous year. And so we were looking and talking about some ways to try to find basically an accountability partner that follows that child along the path And one suggestion that I kind of brought up was a school resource officer who follows the child over multiple years instead of who just sees a child just during 1 year at a time. Have you given any thought yet or had any discussion about, how we can, in the school systems, have somebody who can recognize a change in a child over a period of, not just, a week, but, I don't think that a lot of these problems just begin in one day. I don't think a child one day changes from one behavior to another. I think it materializes over time. Do you have any suggestions on that, or do you have any ideas?
That is a component in actually the suicide prevention training that trains our teachers, because those, as far as identifying it, like that's the front line. They're the ones that the vast majority of the time are going to identify. So they do receive training on how to do this. Now, once you identify a student that potentially needs some support from this standpoint, that is when you end up with the MTSS process that gets started, depending on whether it be academic or behavioral. But also that is with the BTAM piece on the back end that we're starting to work on in Mississippi. That once that student is identified, it also then creates a system in which they have someone assigned to them. So, and not like a following them around everywhere standpoint, but if it requires that, they could. And if it requires that, school resource officers are part of this. It's actually the law enforcement piece is really driving a lot of this currently to help. They recognize this issue. They deal with it every day. Every time they deal with it, someone or pull a car over or whatever. So they're helping drive this. It's a relationship between law enforcement and K-12 that's making this happen. But yeah, I would tell you right now, school resource officers all over Mississippi are serving in that role. They are. Students probably never know they are, but they are.
All right. I'm going to turn it over to Representative Creekmore here.
Thank you, Dr. Evans. When you mentioned where you were prior, the past 20 years, you say that area, what area are you talking about?
North Mississippi and New Albany.
Specifically?
New Albany.
New Albany City Schools?
Yes.
Thank you. I was fortunate enough to serve on his school board, and he did a magnificent job, and we were sorry to see him go, but at the same time excited for the state of Mississippi. So, Dr. Evans, I want to ask you about recess, and there have been lots of studies about how important recess is, especially in the elementary level, in relation to mental health. What is the minimum standards we have in Mississippi for recess?
Actually, it's an accreditation. It's an accreditation standard. Goodness, I can't get my words out this morning. So, and when you're looking at grades, is it K through 8? Yes, K through 8 is 150 minutes a week. That's required in order to meet that standard. And then when you get in your high school grades, 9 through 12, obviously you earn Carnegie units in the middle school grades as well. But when you get into high school grades, that's when a lot of the athletics piece kicks in. You don't see like recess, if you will, for the most part. Now, when I was in school, you did. Like back in the old days, I'm old enough now and gray enough now, I call everything the old days when I was there. But they still had some of that. But now, because of the requirements that are put forth, you actually get it in a Carnegie unit form, which if it's a half a Carnegie unit, it would be 70 hours. So like a half a semester. It's called a semester course on a block, on a 4x4 block. And then 140 hours for a full credit. But yes, sir, it's a requirement. And also you have it's a PE requirement. So they typically meet that through a recess piece as well as a PE piece, if you will, in your K-8 schools.
Is lunch or food time part of this, or is that completely separate?
It is 150 minutes per week to answer your question.
Gotcha. All right. And if a child is being punished for whatever reason, is recess taken away from the child?
No, I'm sure that happens. I'm sure it's happened where I've been. I am absolutely adamantly against that ever taking place. We got to find other ways to address behavior. I would tell you in most cases, addressing behavior in that way causes more of the same behavior that was causing the issue on the front end. Because as a 46-year-old adult, I need a break every once in a while as well, right? Everyone in here, you would agree. And you know, when you were in kindergarten, first grade, second grade, how much did you look forward to recess? You know, you get to hang with your buddies, you get to, that's the social emotional part of it. So yes, that adamantly against anyone who ever uses that as a form of punishment.
All right, on the suicide prevention training, is that for every employee?
Every human being that's employed in the district.
No, that's different from mental health first aid, I assume.
Yes.
Okay, and so mental health first aid is an option for teachers. Counselors, they receive the suicide prevention training, but they're not required for mental health first aid. Okay. That's all I have.
Hello, sir. On the note of breaks, I know several school districts are moving to a modified year calendar. My school district is one of them, and based on like anecdotal evidence just from myself and my,
I really can't hear.
I'm sorry, I'm terrible. This,
Part of it's my problem. I don't,
Can I pull this
honestly, I
one?
don't hear as well, as well.
okay, no, it's me. I did the same thing yesterday. Okay. But from myself and my peers, just like based on anecdotal evidence, I feel like it's been beneficial for improving school attendance as well as mental health. Is there any data supporting that? I know a lot more school districts are adapting to the schedule, or adopting the schedule. So is there any data like backing that up?
Yeah, currently data is being collected in that area. But what I would tell you from, you call it what you want to call it, year-round flexible scheduling, whatever calendar for school year. I'm about to knock the mic off there. I'm gonna break mine and you won't be able to hear me. But what I find there is it does have has somewhat of an impact, somewhat from an academic standpoint, but it has a much greater impact on a mental health piece for your students and teachers. You're taking that same 180-day school year the students are required to get, and it depends on how many contractual days. Lots of times in Mississippi is 187 contractual days for teachers, unless districts add to that. That's where you find the biggest positive, if you will. So, but obviously, if it were easy to do, then everyone would do it though. So what you find, the obstacles to it typically are if you're in an area and you're the only district doing it there, it becomes very difficult because so people who come into your district to teach, I'm going to use a North Mississippi example. So say if New Albany decided to do the year-round schedule piece, well, teachers that come in and have students in Lee County or Tupelo or Oxford, if they're not doing this, well, now you have to consider all this because they have children that are at home when they're not, right? The scheduling piece. Also from an athletic piece, you have to look at it as far as when you're in school versus not in school. None of those are reasons not to do it. None of those are, but it's all obstacles. So what you find is in pockets, you'll notice lots of districts do it in a certain area. But once that starts, it just kind of rolls, you know? And we've looked at it when I was in New Albany. I know Bradley there at Oxford's looked at it. Dr. Piku, Tupelo's looked at it. Corinth, Dr. Childers, they've been doing it for quite some time. So that's a long answer to a short question, but that's yes, there is positive associated with it. But also the last piece, and I don't want to belabor this response, it's very important that you work with your local community because the child care providers have to be on board as much as you possibly can get them to make this happen.
Thank you, John Walker. I think Senator Boyd had the next question, then we'll go to Dr. Edney next.
Couple of questions here, and they're kind of going to be themed with one of the things that we know is that we have a good bit of resources in the state. That many of them were presented yesterday. Sometimes though, and we've seen this in other things that we've worked with on the legislature, it's people actually understanding that those resources are available. And there was a number of things that were presented yesterday. One of the things that you just brought up that I'm wondering about here is you talked about that with the student, it was sometimes 5 days before you could get an assessment. are the school districts actively engaging with their community mental health centers to use those crisis intervention teams? We put some legislation in place this last year, really directing law enforcement to use those crisis intervention teams, because these assessments could happen much faster than 5 days if these crisis intervention teams were used. Can you kind of research that and
I
kinda
will.
get back to us on that? Because I think there may be a disconnect when there's pretty immediate help available in the area. Using these resources again, we know that y'all ran really kind of, the Department of Education really did a model program when the pandemic hit with monies that y'all were given from the federal government on making sure that there were access, particularly telemedicine access for school health issues. And you had about 75 school districts, if I'm not mistaken, kind of take advantage of that, which leaves a number of districts that did not take advantage of that. That program, we found out yesterday, was ending at the end of September. They're looking for some federal dollars, though, to make sure that they can continue some of those services. What kind of bothered me a little bit about a number of those districts that did not accept those services, they are districts that I'm well aware didn't have a great deal of behavioral health supports, mental health supports in those districts. And so I'm wondering if there's kind of a disconnect, again, understanding what those services are that could come in and help school districts. Because a lot of your school districts, being rural, don't have a lot of behavioral health supports. That system was in place, although not, it wouldn't service everything because you do need in-service for some things, but it would service a great number of those options. So again, really concerned that maybe we're not connecting the dots for people on that. So that's something I have a little bit of questions about kind of for that. The other question I want to have too is on this curricula, and we can get more to the Department of Education, back to the Department of Mental Health, and that is these pilot program you were talking about that. Does it integrate, are you aware, does it integrate into the curricula, this program for K-5?
Yes, yes, ma'am.
Okay, so it's integrated into their reading, their math, and all of that.
That's that struggle, because if you didn't do it that way, it would be very difficult. Let's be honest, it'd be very difficult for someone to find time it would be one more thing. That's why you
Okay.
have to integrate it in.
And then do you know when they're evaluating this piece, are they evaluating it looking at the YRBS, what outcome data that you get from this older age group is? And I can't remember, Dr. Edney, YRBS is what age group? What are we?
It's the 16-year-olds
Okay, so that we wouldn't have data on that
for the
yet.
high-risk behavior.
Yeah, that we wouldn't have data on that yet. But what we're kind of looking at to see what the outcome data was on kind of changing behavior as children went through that. I would be interested to see that. And I'll stop with my questions for right now.
Dr. Edney?
Thank you, Mr. Chairman. Dr. Evans, it's so good to see you. I'm Dan Edney over the Health Department. To your point, Senator Parker, that ability to look longitudinally over the life of the student. The other resource I really want to promote are the school nurses, who have been horribly undervalued over the last decade and in many areas phased out, and to the detriment of our children, but also to the detriment of population health. Another impact with mental health issues, which are hyperacute, are still the acute, very important issues of the alarming rates of diabetes and hypertension and childhood obesity among the school-age population, which actually kills far more of these individuals than anything else combined. It just kills them later. It kills them when they're out of your jurisdiction, but they're under my jurisdiction their whole life, so I have to worry about all these issues. And, I want to make sure that, agency head to agency head, that Department of Health wants to be a very good partner with your important work. And I think with education, health, and mental health working collaboratively together, we can just not improve the health of school-age children, we can improve the health of the entire population. Because a lot of the things I'm fighting, I have no hope in this world to make better unless you and I can work together for just basic health education as early as we can get it. And that certainly includes what this task force is working on. But those school nurses can play a pivotal role with mental health. They can pick up on things that a resource officer is not going to pick up on. So I think we need to look at all the opportunities we have for this really important topic. And I appreciate you being here. I look forward to working with you.
Yeah, and I appreciate you bringing up that about school nurses. They are unsung heroes all too often, especially the ones that I worked with for the last 18 years. Tammy Reeder is her name. She's our director. I feel like I need to say that. She's our director of health services. You are absolutely correct. They wear so many hats that aren't what you would think is the norm with helping students, and thousands upon thousands upon thousands of visits per year that they see. I mean, they sometimes they're not a primary health provider, but they almost become a primary health provider for so many of our students. Thank you for saying that. I should have put that in here. Thank you for saying that. But yes, I absolutely want to be a partner, and I will reach out to your agency and we'll sit down. Thank you.
Go here and then we'll come.
I'll try to be quick. I have a few questions. When you mentioned the 400 to 1 student to counselor ratio, you made sure to make a distinction between like school-based counselors versus mental health counselors. Do you know if that 400 to 1 is that's school-based, or does that include both?
Those are school-based counselors.
Okay. Do you know any ratios for how many like mental health counselors are in the schools currently
No, sir,
per student?
I don't. And it would be hard to calculate because you have so many students receiving support that's from outside. Yes, sir.
Do you know what other states, maybe somewhat similar to our state, what kind of ratios they have for student counsel, for
don't have
school-based
that.
counselors to?
I don't have that with me, but I can look. I can look at it.
Okay. A few other, I made a lot of notes, I'm sorry. So for suicide prevention, I noticed there was a lot of training, both from the Department of Mental Health yesterday mentioning about first aid and some of the programs y'all run for teachers. Are there any educational or preventional strategies taught to the students directly, or is it always aimed at the adults? Are there any educations about suicide and recognizing signs in peers and working with and what to do if you think a fellow classmate? Is anything aimed at the students, or is it all staff-based currently?
Primarily what you're going to find is once an issue is identified in with a student, that they need some support, that's where that's going to come into play. But as far as like a blanket, everyone is required to go through X training directly to the student.
Or like when I was a kid, we used to do like assemblies, like
sorry?
like when I was a kid, we'd have like assemblies. You'd go into the assembly room and everyone would get like a big mass school talking to or something like that. Does anything like that happen for suicide prevention or recognizing suicide warning signs?
Yeah, you see that in schools. I mean, but we don't have like a defined, this is what you say, do it this way, do it. No, sir.
Okay.
It is, and that's a great point. That is a great point, because sometimes we could, and just thinking through that right quick, you could equip the students as a whole in what support services are there for them. So yeah,
in clinical psychiatry, there's a lot of research that shows that if you equip the students, like they've done pilot studies where they've gone in and tried to equip coaches, teachers, what they call gatekeepers, people that are in those students' lives. And they find that there's actually not a huge reduction in suicide risk and suicide attempt in those communities. But when they go in and equip the students themselves, they actually do see some dramatic decreases in suicide, not ideation, but attempt. And so that might be something we can look at. On the phone situation, you said you did not think it would, like a hard blanket ban would be.
I'm sorry.
Hard.
Yeah.
No, you're not. I'm working. These are new to me.
But on the phone situation, you said that you did not think a hard blanket ban would be a really good idea. There may be some pushback, some risk that comes
Yeah, I didn't
along
say it
with
wouldn't
that.
be a good idea. I said, I think that might be where you might get some pushback.
Do you think in your role and in your experience that that pushback's worth looking at that as trying to push something like that regardless of the pushback? Like,
Yeah,
do
I
you think that's
think-
worth it?
Well, I don't know why we wouldn't look
Okay.
at it. I don't know why we wouldn't investigate it. Because I think you're going, anytime you do something, there are going to be people on both sides of it. So you just have, in the end, you have to just make a decision as to what's best for the whole. And that's, yeah, I don't think that's definitely not a reason to investigate it.
Okay. And I have one more question and that's where I'm done. On the safety assessment, so when a child is identified that has said something that is threatening either to themselves or somebody else, you mentioned that very frequently they require, it kind of goes into the realm of the school-based counselor, and they very quickly usually say they're going to need some sort of assessment. And as a child psychiatrist at UMC, I see a very, very, very large number of those cases locally, from Hinds County, Rankin County. People don't usually come to me from far away for that, but I've had as far as Warren Yazoo County, someone have to come in the middle of the night for an assessment. And my question is that, so it's obviously time consuming. It's awful for the families. Do you have any thoughts, ideas, data about what might be a really good way to better accomplish that? Whether that be equipping people in the school system, working with the local mental health centers. Is there a way that you see how that might play out better in your experience? Because I think based off the way you worded it and based off my experience, the way we do it now is very
working.
inefficient. It's a waste of money. Mitigates risk quite a bit because you're getting them in front of the doctor or something like that very quickly. Well, not always very quickly, but you're getting them to that level. So it's a great risk mitigator, but it seems like it wastes a lot of resources in a lot of other ways. Student time, family time, ERs, it floods ERs with patients who, I've seen a 5-year-old who got upset and said, I'm going to kill you. And there's not a lethal bone in that child's body, but to mitigate risk, we have to have that child assessed. And that ends up being a ER bed tied up for maybe something else because it's not, the risk level is actually pretty low. Do you know, or do you have any experience in how you would see that designed?
Yeah, so I think coming at it from a little bit of a different approach is ensuring that those students that are referred for that actually need that. So that is, I think that's the way we as an agency can impact it the most, the quickest, if you will. And that's, like I said earlier, the meeting that we're having at the end of August to start to look at implementing that system statewide. Because the thing is we have you just said it, there's limited resources. So we have to make sure and maximize the use of those. The last thing we need to be doing is for 50%, I'm just pulling that number out of the air. Okay, that's not an actual correct number, but 50% of the students who you see did not need to come. But you have to have a system in which people are trained to identify it. Because in the world today, let's be honest, we live in a very different world. I was born in 1977. The world's very different in 2024 than it was in 1977. So, and you said it, lots of times the reason why students are sent on is that to mitigate that risk that they might potentially do something.
So before we move on to Dr. Hogue here, thanks, Dr. Baker, for bringing up a couple of things. I've gotten a couple of questions kind of through social media here. And to one thing I wanted to follow up on, I think something that would be helpful to us on the cell phone issue is if you could have a survey done of what the local districts are doing right now and what their existing cell phone policy is, because Marshall County is instituting a local policy. I think it'd be useful for this group to know
That's in the works
what's
right now.
actually being done. And you could, in putting that together, your staff could, after you get a few things in, you could come up with, they're doing this, you put in 4 or 5 different boxes and then just include it. You don't have to, have every single policy listed out, but you could, kind of quantify them and then get that to us. Because I think as we look at this, that would be useful and helpful for us to know, okay, what's being done across most
for things that probably like ER visits and sometimes hospitalizations. So rather than that being dealt with in an integrated way with a lot of the steps being at the school level with everyone working together. And I also want to agree with Dr. Baker. It's really important. We've heard evidence-based tossed around a lot. We really need to look at what that means and what kind of data supports the different interventions that we're talking about. So that's not so much what you were talking about, but I really appreciate what you said. We need data. So anyway, I'm so excited to hear all this and that you're in the position you're in, and we want to work with you. That whole issue about threat assessments is huge. And Dr. Edney, my child never could have gone to school if it hadn't been for his school nurse. So she saved his physical health and his mental health. So I think that's it.
So we're going to do one more question. We're already running a little bit behind, but I figured we were going to give you a little extra time, and we may even, as this kind of progresses along, either ask you back or someone else from MDE, because I think
We'll be more than happy
are
to do anything you need us.
one of the most key partners in what we're considering here. But one more question, then we're going to go to the next. So.
Thank you,
Please,
Mr. Chair. And
please.
Dr. Evans, thank you. First, thanks for grounding the conversation. It's like one of the most critical things we can do for our students. If their mental health is not going well, who could care about an XY interslope?
Yeah.
So thank you for that. Also, just I appreciate the kind of outside the box thought around how we might creatively run at a workforce. Maybe not the same credentialing as you mentioned. And maybe we think in terms of care force as opposed to traditional workforce. I thought that was a great kind of thought. Also, thank you for the focus on the teachers. We've got to take care. I know the retention and issues to keep our students, to keep our teachers, because they're doing what they were called to do, to teach, as opposed to being a frontline mental health provider. And so caring for them, and then I appreciate the broader ecological perspective to care for the system surrounding them, and in particular, how we care for the families. We've got to do a better job pulling them in. I love the resource officer idea, Mr. Chairman, and sometimes they turn over, right? So we want to make sure that the one constant variable in their life, their family, God forbid they stay together, right? We do a great job pulling them in to equip, to notice those changing behaviors you mentioned. My question is, and Representative Creekmore, you mentioned that about recess, which got my wheels spinning a little bit. And then Dr. Edney, when you mentioned that about the school nurses, my wife was a school nurse for many years, by the way. She's a rock star. But I started to think about, like, this is my question for you. Is there a way to kind of reimagine that recess space in light of where we are in the literature of holistic integrated care, mind-body connection with gut, with all the things that lead to the longer term kind of physical health consequences, the ACE studies that we learned about, knowing who's at risk, and how we do mental health and healthcare integrated education in that space that we have historically held for just physical health recess. Is there a way to reimagine that? That's more of a question between the two of you, but I don't know if the curriculum would allow for something like that, but is that possible to reimagine that space, to have more mental health integrated into what has historically been siloed as a physical health?
Yeah, I mean, I'm open to anything. I really would like to see how people maybe have done that, to have some ideas. I would have to I need to see how that's working, I guess, if that makes sense.
I'm thinking the
Educate
curriculum, like you were talking about earlier. Is there a way to integrate that
Oh, okay.
curriculum?
I thought you were
and-
talking about like changing the way recess is set up.
Well,
to do
I'm
that.
thinking more the placeholder of recess.
Okay, I got it.
Like when you're looking at your number of minutes, you have to account for in the course of a student's day.
Yeah, I mean, to be honest with you, we can operate in whatever way we see fit to be best to educate a student. So we can make the thing we want to always be mindful of is making sure. I'm an advocate for, if we put something on people, we need to take something away.
100%.
You see where I'm going?
100%.
So because if we want them to do it. So because it doesn't matter what you know, it's what you can convince someone to do. We know this. You can have all the answers, But if people won't work with you, then.
It can't be an
Yeah,
add-on.
there
It
we
needs to
go.
be integrated. That's
Yeah, but
exactly what I'm
yes,
saying.
there, we can adjust to however we need to adjust. Obviously, there's standards and accreditation, accountability, we do all these, but I'm open to anything we have to do to make sure that our kids are taken care of. Our kids and our teachers are taken care of.
That's
So,
right. Thank you, sir.
yes. And Senator, I promise you, I have two, one that's driving and one that's in the process of getting his license. He's got the day he's counting down, and they wish I would have sent them somewhere else. They'd much rather have their mother ride with them than their father.
Right. But again, thank you, Dr. Damon, for the question. And Dr. Evans, your input today is extremely valuable. It will be considered in everything that we go through here. And we certainly, if you could, just as a takeaway, get the information on the cell phone
Mhm.
as a survey, through your staff. If you could get it back to us, we're looking to have this report done as a report to the legislature by October 1st. So hopefully that's not going to put too much of a burden on your staff to get that together. And we'll certainly bring more questions as we come. But again, thank you for being here, and we're going to move right along to our next speaker.
Thank you so much for your time. I appreciate you. And I do have to leave. We have a board meeting. That's why. Yeah.
We appreciate you. So again, like yesterday, instead of taking a break between speakers, we're just going to kind of allow a little introduction time and that kind of thing at the beginning. And that allow, if you need to step out for a moment to use the restroom or something like that, you can do so. But our next speaker today, we have Kimberly Wheaton, the Deputy Commissioner of Child Welfare for Mississippi Child Protect for Mississippi CPS. She's going to present to us. And so if you would, I don't know if he left the microphone on there, but if it should be lit up with a little green light there. And if you would start out by just introducing yourself, telling us a little bit about what you do. And then I know you've got some remarks prepared and we can follow those with questions. So welcome.
Absolutely. Thank you. And I'm new to this microphone too, so I'll do my best. And I think sometimes I'm a little soft-spoken, but I'll try to project to the room. Good morning, everyone. It is a pleasure to be here and speak to you all on behalf of the Mississippi Department of Child Protection Services. My name is Kimberly Wheaton. I currently serve as the Deputy Commissioner of Child Wellbeing and Permanency for the agency. A little bit about my background. I'm a licensed clinical social worker here in the state of Mississippi. I'm a graduate of Jackson State University, a graduate of Belhaven University. I have degrees in psychology, social work, and leadership and human resources. The thing that brought me into this profession was as a teenager, I developed an interest in mental health, just watching some of my peers grow up, some of the things that they and their families were experiencing. So it is more than a pleasure to be here today. It is a passion to be here to talk about mental health and how we can meet the mental health needs of our K through 12 population. Just a little bit about my work background. I've been in mental health since I left high school. I started as a direct care worker at Mississippi State Hospital. I worked on a male building, building 35. I still remember the number. And from there, I made my way through social services, through the mental health profession. I've worked at the Department of Mental Health as a program administrator, and I've served at Child Protection Services in various roles. And I also do some adjuncting at some of our state universities. So that is enough about me. Today, I have with me as a lifeline and a support, one of our many deputy commissioners, Mr. Devon Loggins. Devon Loggins came to us about 18 months ago from the Methodist Children's Home Services, where he served as the CEO at that time. He has an extensive background in running congregate care settings, in training, and he is a body language expert. So not only is he my lifeline today, he will also critique me and give me some feedback when we return to the workplace. So today, our primary goal is to present to you all on behalf of our Commissioner, Andrea Sanders, and our other leadership members on our organizational makeup, but also how we intersect with the mental health system and what we do to try to be a partner in meeting the mental health needs of children, not just the children that we serve daily, but the children that we come into contact with by way of referral or just connection. So. I believe I have a clicker here somewhere. But just to move forward a little bit, our slide says it's a new day at the Mississippi Department of Child Protection Services. Over the last few years, we have moved into some transition. Our new commissioner, and she's not new anymore, I don't think I can keep saying that, but she's been with us 4 years now. And she came into the organization and did some assessment of our workplace organization, what our strengths were, what our challenges were, and from that, we started to make some internal changes, started to change the way we work with our partners, our community, our other state government partners, and we started a little bit with transparency, just being honest about where we were and what we needed help with. So as a result of that, one of the things that we did was we moved into a specialization of our workforce. So for many years, the child welfare system has been structured in a way that every case specialist was responsible for everything for every child on their case load. So we recently, about a year and a half ago, we changed that structure so that we have case specialists that are responsible solely for intake and investigative work, but we also have case specialists that are responsible for the ongoing work of children that are in foster care. We did that for a number of reasons, because it was difficult for our workforce to be experts in everything. When our children do not return home through permanency, they remain in foster care and go to permanency either by adoption or by way of durable legal custody, durable legal guardianship. And so with that work comes that the specialist needs to know how to get a child to through the process. How do you initiate terminating a person's parental rights? How do you get a child through the adoption process? And so because our staff struggled with being experts in all those pieces, they moved to that specialization. As a result of that, there have been some challenges, but we've seen some strengths. Our workers have become more comfortable and confident in their court testimonies. We still have some struggles because we take a lot of college students or college graduates fresh out of school that come to work with us. So it takes a lot of training and a lot of support. We like to say that it takes a person about 2 to 3 years to really master this work. So on the screen, you see the agency overview. It's broken down into about 4 primary categories when you think about the foster care work and the work that the Child Protection Agency does. The first would be intake and investigations. And our intake is when that call comes into our hotline. We have a Mississippi centralized intake, which is a 24-hour hotline. We also offer 24 hours e-reporting. We have a combination of social work degreed individuals and related degreed individuals that man that hotline and take those calls 24 hours a day. The other category there is our foster care. So that is when we receive a report on a family and that child is unable to remain safely in their home. That child is then placed in the custody of the department, and our foster care staff oversee that work. One of our other departments that you may not hear a lot about is our prevention services department, and I'll talk a lot about that department today. Our prevention services department has about 10 staff right now, and they're a support unit to our frontline workers and to our community. We also have support services, which is the work that Deputy Commissioner Devon Loggins oversees. And our support services units consist of our youth transition and support services. It also consists of our interpreter services, our foster care licensure services, our ICPC, interstate compact work. And our professional development and training is in that department. So I talked a little bit about our intake and how our hotline operates 24 hours a day. One of the assessments that we made when Commissioner got there is that we don't have a really robust screening tool. Our screening tool that we currently use it's homegrown, home developed. It's a combination of about 6 very specific questions at the end of the call that routes the call to either a level 1, a level 2, or a level 3 community response. A level 2 community response gives us 48 to 72 hours to assess the family's needs, to get out to initiate what is really going on. And then the level 3, we have 24 hours to respond and assess what the initial need is of that family. So we realized that we need a more robust and evidence-based way to screen those calls and to make sure that our early responses are very thorough. So we're right now in the process of implementing a structured decision-making screening tool. We're working with a company by the name of Evident Change. It's an evidence-based model and it's used in multiple states with their hotlines to assess the calls and it has a screening guide tree to determine how the call is routed. Another benefit of that work is it is going to allow us to also implement an additional community response. That community response will allow us to engage families in more preventative services in the beginning of our contact with them. Right now, we have 2 pathways to our prevention services. And one of those pathways is that the call comes in, the work is assigned to an investigator, and then once the investigator engages with the family, they can determine that that family needs those preventive services. They will then make a referral to that prevention service provider. Another way is that we can have an open case on a family. We get an investigation, have an open case, and from that open case, the case specialist determines that that family needs some preventive services. Well, we learned that those prevention pathways don't allow us to be very proactive. And so once we have our structured decision-making model in place, it will allow us to screen those calls on the front end that are a better fit for preventive services from our community partners. Those prevention specialists will then contact those families to say, hey, we received a call on you all, or you all made a call to us, and we recognize that you may have some needs that one of our community partners can meet. And we will then refer that family to that prevention provider. We also implemented some robust in-home services because we want foster care to be a last resort. We want to keep families safely intact when we can, but we know that that is not always the option. Some of those robust in-home services include Intercept, which is an evidence-based model that we use. Encircle is another Mississippi homegrown model that is provided by Canopy Children's Solutions. And just recently today, as I was coming into the meeting, I received some data from our provider that does Intercept. And they categorize the referrals that they receive based on need. The top need was families experiencing abuse and neglect. The second need was behavioral health, and the third need was educational services. So everything that we've talked about or are talking about in here for the last 2 days definitely intersects, and we definitely all have to do it together. So just to give you a little overview of what the Mississippi foster care system looks like right now. As of yesterday, we have 4,027 children in our foster care system. Some of the counties where we have the highest population of children in care are Hines, DeSoto, Lee, Harrison, Lowndes. We have 225 children in foster care right now in Hines County, 214 children in foster care in Jackson County, 246 in Harrison County, 177 in Lowndes County, 181 in Lee County, and 125 in DeSoto County. Out of that population of children, our children are placed in a variety of placements when they stay in our care. We start with relative placement. We seek out relatives that can provide care for those children. If we're unable to find a relative that is able to provide that care, we move into looking for a foster home for that child. Those children that have medical or mental health diagnoses and need extra support, we also then seek out therapeutic foster homes or group homes. We also work with a couple of specialized medical and mental health treatment facilities. Out of that population, we have approximately 500 youth that are in a specialized treatment setting. So what that means is that we have 500 youth that are either in a residential treatment facility, an acute care facility, a therapeutic group home, a therapeutic foster home, or another type of medical treatment facility. We have approximately another 40 youth that are in what we're now calling our adolescent diversion unit. As we think about or talk about our partnerships, we have partnerships with Canopy Children's Solutions, with Youth Villages, Catholic Charities, Hope Villages, Methodist Children's Home, Southern Christian Services, our community mental health centers that Wendy Bailey presented about yesterday. We also have a couple of other community providers that we work with, such as Baptist Children's Village. I don't think I mentioned them. I don't want to forget anybody, Families as Allies, but just to name a few of the collaborations and partnerships that we have. One of the most significant things that we recently had to do to address the mental health needs of children, primarily in foster care, is that we had to reach out to those partners to ask them to extend their partnership to us and to help us establish these diversion units. What these diversion units do is reduce the number of children that we will have to place potentially in a hotel. That is no secret. I think we received some recent media about placing children in hotels. So primarily, those are children that are in our custody that have some complex acuity needs that local providers, parents, foster parents just are not able to meet. We do put every foot forward to keep those children safe. We do put them in hotels with sitters and with staff when that is necessary. But the diversion units were established to help prevent or reduce that. So with Baptist Children's Village, they have a facility that they allowed us to use that we currently staff because of the staffing shortages in the state right now. Canopy Children's Solutions, Hope Villages, and Methodist Children's Home also allowed us some space for diversion units that we contract with them to use. The other thing that I will say about that population of children is they are diagnosed with many of the things that Ms. Bailey and the doctor from UMC talked to you all about yesterday. I looked at the recent data of our children that we have unfortunately had to place in hotels, and many of them have diagnoses such as anxiety, PTSD, bipolar disorder, polysubstance abuse disorder, schizophrenia in some of our children. And some of the children that we had placed in the hotel but were able to move were also youth with intellectual developmental disabilities. So our role in addressing child and adolescent mental health. There are various things that the agency does to try to help be a system partner and meet those mental health needs of the children. Assessments, we assess our own children. We still need psychosocial and psychological assessments, but when children come into foster care, we have a partnership with a private provider and a CAFAS, a child and adolescent functional assessment is conducted or completed on our children with therapeutic needs. We're in the process of transitioning to the CANS, the Child and Adolescent Needs and Strengths Assessment. And what we hope that that will do is also improve our ability to be proactive in placing our children to identify some of those mental health and behavioral health needs early on that we may not be catching. We also send our children for mental health assessments that are 4 and older within 60 days of them coming into foster care. Collaboration, we participate on various committees and roundtables just to inform our partners and our state on the needs that we see in children and families as we come into contact with them. We sit on the State Interagency Coordination Council. We're currently participating in a roundtable with Hinds County and the Jackson Public Schools around the trends that we see in abuse and neglect reporting and the critical needs of the children in Hinds County, Mississippi. We also have recently participated in a cross-systems partnership meeting for meeting the needs of high acuity youth that was sponsored by the Casey Family Programs. And we took members, representatives from the Mississippi Department of Mental Health and the Department of Health with us, along with Canopy Children's Solutions and one of our youth court judges, so that we could sit with other states and talk about and work around the issue of addressing the needs of our children with high acuity needs. One of the things that you will find with this population of children and with the mental health needs of the children that we come in contact with is that the children now are expressing their trauma and their behavioral health in ways that are too challenging for their caregivers. Too challenging for their caregivers and too challenging sometimes for the facilities, the local facilities to manage the behavior. So as a result of that, we've started also using a portion of our prevention funding to support training, training for our foster parents, training for our congregate care providers. We're training on things like trust-based relational intervention, which is attachment-based training modality. It's a promising training. It focuses on connection and it gives parents some alternative behavior modification, if you will, techniques. And it is sponsored or was started by Texas Christian University. And it was actually started for parents primarily who were adopting children. And some of those children also had autism. Well, from that, they recognized that the techniques that they were using worked not only for that population, but for other children and even for some adults as well. So they started to expand the model. We became familiar with the model because Judge Favre in Harrison County, I believe, he was the first to get the training, and he came to us and he said, I've been using this in my courtroom and it really works with children and families. And so we became interested in it and learned more about it. And so we have recognized that it's important for our schools, our congregate care settings, to all be trained in that. Because what it teaches us as a system that works with children is to speak the same behavioral language to the children, so that they aren't confused by what we as the adults mean. Or when they're in those moments of crisis, they get very familiar with hearing things like, let's negotiate this behavior. Let's go through our choices today. And so as we all talk that language more to them, it becomes more impactful. We also work to educate our school systems on their mandating reporting responsibilities, but also what can the education system do before making the report? What are some things that they can put in place to assess the needs of the students that they see every day, even before we see them? And lastly, I would say we need you. We need this task force. You know, I was tasked with giving you all information on our overall agency structure, talking about our interaction in the mental health system and where our work intersects. But I believe one of the biggest things that I wanted to say to the task force today is that it takes a collective effort to take care of the children in Mississippi and to meet their care needs. We overall, and I'm trying to choose my words wisely because I don't, overall, we are in a very unique position because we serve as not only the parents of the child, but we serve as a part of this great system in the state of Mississippi. So sometimes I have to put my parent hat on and I have to call, you know, my partners and my friends and ask for favors and guidance and support to take care of our 4,000 children. Sometimes I have to put my systems hat on to determine how we as a system can make those big systemic changes to meet the needs of all of Mississippi's children. So I think the biggest thing to take away today from Mississippi Department of Child Protection Services is that we make every effort to meet the needs of the children that we serve, both in foster care and outside of foster care. We are a willing partner. So if there's anything additional that we can do, we're open to do that. From a needs perspective, we need help with our high acuity youth. We need help with our older youth. We need more resources. We don't want all of our children in group care, but there are still always going to be those children that need it. And when we don't have a bed or a place to take them to get the treatment that they need, we have to try to create the treatment. And sometimes we have to try to create that in some unideal places. And so that is what I will leave you all with today. I will take questions and give the best answers that I have available today.
Thank you. Thank you, Kimberly, for that update. And I guess I'm going to direct just one question of mine to Dr. Damon, because there is a good bit of information that you provided on the divergent population and how you have them working with Canopy to some degree. So Dr. Damon, could you tell us how Canopy is working, you know, in this program and what role you've had and how you see that as beneficial, or what your perspective is on the partnership with CPS?
Yeah, thank you, Mr. Chairman. The diversion program specifically, yes, sir. So for over a decade, we have partnered with CPS for kids who abuse and neglect has been reported and confirmed. And then, but the child is not imminent risk at that point to go into the homes and work very intensely with those families to both prevent them from entering state custody, or for those who already have, to reunite them with their families. And so I they're heroes doing the work, to be real honest, that do it in great collaboration with our partners at CPS. But for over 10 years, there's been a 97 to 98% success rate of actually keeping those kids and families together. And since 2019, have diverted over 6,000 kids from entering the state's custody. Just to support that and thank that work and that partnership, and I think that public-private partnership together to try to keep kids and families intact. Because what I've learned is these are families, again, who abuse and neglect has been confirmed. So that the fact that they're free of abuse and neglect following says that these families can do it, but they need some help. And so I think these concrete supports that we can wrap around them and support them and train them and equip them to be the parent for their kid, not the state, is a beautiful thing to watch, and to watch these families thrive after they get just a little bit of support. So I'm grateful for that partnership, and I think it's a testimony to Mississippians being able to be successful when they have those concrete supports and resources and connections back with the resources in their local community to be successful.
Very good. Now open it to questions and start with anyone on the panel has questions. Dr. Ho.
Thank you for this. It was very nice to see you, and I'll see you, Devin, and thank you for the work you do. Y'all brought up something that I hadn't really thought about related to this panel, but it's probably very important. And that's that a lot of times those children who present with mental health challenges, but also have a developmental disability, the mental health challenge tends to get a lot of attention, but then they may end up in situations where they may not have the capacity to respond to mental health treatment because of their developmental disability. And with some of the hardest to serve children, that's an issue. So I just think I'm so glad you brought that up, and just something that as we do this work will be important for us to keep in mind, especially that when children are identified as early as possible and looking at everything that might be an issue and the different types of support. So thank you.
Thank you, Joy.
Senator Boyd.
You gave first of all, thank you for coming with the wish list that you
Absolutely.
gave at the end, but I don't want us to miss that list. Would you resubmit that to us in writing? Because you gave some very important things that we can do on the legislative end to increase the supports. And we've done a great deal of stuff over this last 2 years, really try to increase supports and give additional funding in those areas, but we still have work to do. So would you resubmit that list to us? The other question I have for you is, consistently I hear from the caseworkers in my area and CASA volunteers is that it is difficult to find a number of professionals in our area. But we have to drive a great distance to get children those mental health assessments that are required. And I do think those are very, very important. One of the reasons that I've been told by the professionals in the area is that the reimbursement from Medicaid is so low that we have limited people who will accept that lower reimbursement. Can you find out if this is difficulty across the state or if this is unique to the North Mississippi area?
Yes, I will definitely look into that, and I will give you all the additional information that was on the slides. I will just say anecdotally, for the last 5 years, since I've been back with the agency, we do experience challenges getting those mental health assessments. It's primarily those psychological assessments that we need with the IQ scores. And I think that is because there is a small number of providers in the state that can do those, and maybe possibly because of the funding for them, but I'll get some more information.
Thank you.
You're welcome.
So again, we thank you for being here. We are running a little bit behind schedule. So if anyone has any additional questions, we can compile those and get those in the feedback time. So thank you, Kimberly, for joining us today. And we're gonna move right along to Cale Smith, Executive Director, Mississippi Community College Board, is with us today. And just like on our previous presenters, if you would just give us a little background about yourself. We all know you, but a little information would be good. And then the data you can share with us that hopefully can be helpful to us in our work here. So thank you again for being here.
Yeah, thank you, Mr. Chairman, for allowing me to join y'all today. I am Cale Smith, and I'm the Executive Director of the Community College Board here in Jackson. I've been with the agency since 2008, serving as Executive Director going back to January of 2023. And so it's an honor to be here today. I want to begin by thanking Senator Boyd, Senator Parker for your leadership in getting 2727 through the finish line, and Representative Creekmore for your leadership in getting it out of the House as well. You know, this is a critically important topic that touches so many lives, and it's life-changing in so many different ways. And so y'all are to be commended as legislators for your leadership on this effort. Members of the task force, thank you for what y'all do, y'all's commitment to mental health. Y'all are in the trenches each and every day, no matter where you're employed. So thank y'all for taking some time out to lend your expertise to this very important subject. So today I'm going to try, Senator Parker, to get you back on time, if that's all right. I know you said you're running a little long right now. My presentation will cover three main topics. First is just an overview of the community college system. Second will be current mental health services that are offered. And then finally, just service gaps and barriers that we've identified that were shared with me. And then I'll also cover kind of looking ahead, best practices, that sort of thing. So whenever I have the opportunity to speak before a group, as the executive director of our agency, I at least like to give our mission statement. So the mission of our agency is to advance the community college system through coordination, support, leadership, and advocacy. So for those of y'all who don't know, we're the coordinating board for the 15 community and junior colleges. We have lots of different responsibilities. We were established back in 1986. We're kind of the all other duties as assigned, if you will, for the community college system. We work closely with the colleges to ensure they have the resources and tools necessary to educate and train their students. So jumping into an overview of the community college system. So community colleges today, those of you who may not know, like I said a second ago, we have 15 community colleges that are created in state law. They have geographically identified districts that are also established in state law. Our colleges offer academic courses. They offer career and technical education, about 130, 156 CTE programs. Those are the programs for folks looking to enter the workforce. We offer non-credit workforce training, and then we also offer adult education. We have a significant number of Mississippians without a high school diploma, and so our office is the State Adult Education Office. Each college has its own local board of trustees who hires the president, and they set policies that govern the day-to-day operation of the community college campus. So in academic year 2022, this is a couple of years old, we educated 95,000 Mississippians, and 55% of those were in the academic track. About 20% were in the career tech track. About 20% were dual enrolled, dual credit, and then 5% were adult education students. And then you can see last year, we awarded almost 19,000 degrees, certificates, credentials to about 15,600 students. So who is a community college student? Our average age of a student is 22 years old, so typically a non-traditional student. They're female. Overwhelming majority are Mississippi residents. 63% are full-time, 57%. This is in fall 2022, so it's a little different from that figure I gave you a few minutes ago. Fall of 2022, we had 57% in the academic curriculum, 57% were sophomores, and then 19 was the average ACT. Taking a deeper dive, and not necessarily the numbers perspective, who is a community college student? You know, oftentimes a community college student is a first-generation student. This may be the first time that they have ever gotten away from home if they're living in a dorm. Some are at risk of dropping out. We say in our world that some of our students are a flat tire away from dropping out. And what we mean by that is oftentimes students are looking for a reason to just drop out. And so that flat tire on the way to Raymond, Mississippi may be that reason for them to drop out. Some may be single parents, some may be full-time employees. It's oftentimes could be the first time for students to experience academic struggles in their lives as well. And the majority of our students are what we consider to be commuter students. They come to campus for their classes and they go back home or go back to wherever they're going. They don't necessarily live on campus. I'm sure y'all have heard this before beginning yesterday, but the challenges the students face today are unlike anybody has experienced around this table, myself or in this room, with social media, with just pressures that were not existent when I was coming out of high school 25 years ago. And so oftentimes those are unimaginable for us. So anyway, just wanted to mention that to y'all. So I reached out to the colleges as the coordinating board and asked them to provide me, a list of current services that they offer. In the interest of time, I'm not going to read the 20-page responses that they provided. So I'll give y'all just a Cliff Notes version. So these are some of the services that they offer that were shared with me. Obviously, in-person counseling, mental health counselors on campuses. If a college doesn't have a mental health counselor, they have other staff that are trained in that area as well. This can be short-term counseling. It can include opportunities to educate students on self-care, time management, coping skills, anger management, issues that are critical to the success of people. Part of the importance of the in-person counseling is these counselors can develop relationships with students. And oftentimes that is critical to their success, both academically and outside the classroom. Some of the colleges offer telehealth counseling. Some of the vendors they use are Timely Care, Mind Health, and Pingy, I think is how you say it. Obviously, telehealth counseling allows for after hours opportunities. Mental health issues don't stop after 5 p.m. on Friday. Y'all know that. And so the telehealth counseling in today's world that we find ourselves ever connected is critically important. Crisis intervention for urgent mental health care concerns, that can be done after hours for students if they're experiencing, like I said, an incident or something after traditional hours. They offer health and wellness fairs to educate students on mental health, among other topics, trying to promote the overall well-being of the student. They provide referral services, so if there's an issue that maybe the counselors aren't trained in, they can refer them to professionals that can help address situations. Zen dens is something that a couple of colleges had mentioned. These are meditation spaces, relaxation space provided to address stress, anxiety, and feeling over the sense of overwhelmingness. Pet Partners is a pretty cool service offered by one of the colleges. So I mentioned a second ago, college may be the first time that students experience academic struggles, and that includes finals. And y'all know how stressful that time of the year can be for students, especially if it's your first time to go through that process. And so what Pet Partners are is they provide therapy dogs for students during examination times. And that has been successful and a fairly efficient, I think, program to offer to help students cope during what could be the most challenging time of the year. And then finally, professional development for faculty and staff, just educating our folks on things to look out for as far as mental health, mental well-being. This includes resident directors and RAs. Oftentimes, those folks that are in the dormitories are the ones that have the most interaction with students. And so we want to make sure that our folks in the residence halls are educated and have the proper training to address mental health issues as well. Now, in the course of a semester, I don't have the exact number, Mr. Chairman, but hundreds of students take advantage of all of these programs throughout a semester. Obviously, this is not an exhaustive list. I just wanted to highlight some of the more, I guess, popular issues or programs that were shared with me. So if I can get the clicker to work. Doesn't look like it's working. So I believe you'll have the presentation in front of you. Okay, I will just transition over to the paper copy. Sorry about that. So moving on I asked the colleges, okay, in addition to the services y'all provide, share with me any gaps, barriers, issues that y'all have. And so this will come as no surprise to y'all. Funding limitations is the top issue as far as training for mental health goes. The apps that I talked about, those 3 apps, those cost money. Training costs money for faculty and staff. Staffing and provider limitations. Some counselors have dual roles on campus, much like many of y'all around the table, lots of different hats that you wear. And so as a result, the counselors can be stretched thin because of that. Not enough staffing. We've seen the number of students reaching out for mental health help increase the last few years. And so staffing at times has not kept up with that. Provider limitations, what I mean by that is, I think it was mentioned a second ago, and Senator Boyd, you kind of hit on it in that question. Our colleges are in rural parts of the states, our main campuses. And so oftentimes they're healthcare deserts, if you will, and they're just not counselors in the down the street. And so that can be an issue as well. Student transportation. Sometimes our students don't have an opportunity or a mode of transportation to go 10 or 15 minutes to a healthcare provider to seek counseling that may not be available on the campus. Stigma and cultural norms. Let's be honest, 2024, there's unfortunately, in some instances, still a stigma about mental health. And especially with young people. And so that was one thing that was mentioned, having to overcome the stigma of just mental health and hey, we need help. I need help. And what do I do? That was one of the barriers as well. A quote that somebody provides me is that students are often afraid to ask for help and fear that nothing will change even if they do. So that type comment was shared a couple of times. And then the last gap or barrier that I'll mention is affordability for students. Some of our students have health insurance, some don't. And so lack of health insurance oftentimes prohibits, inpatient, outpatient services that are available to them. So I will say those are challenges that have been provided, but like most anything, those challenges have provided opportunities. And so part of that is our colleges have partnered with local mental health regions to provide services. They partnered with local hospitals and other nonprofit entities that focus on healthcare. I think of the Delta Health Alliance up in the Delta, that comes to mind. So even though we do have barriers, we are trying to meet the challenge head on. So looking ahead, kind of where do we go from here? What can we do better? I think a more comprehensive approach is needed. I think we need to continue to build on partnerships, particularly as it relates to with mental health, local and regional mental health facilities. What does the student of tomorrow look like, and what are his or her needs? And what I mean by that is who would have thought 5 years ago that our students would have been impacted as they have by COVID. They were isolated and socially distanced, and their routines were completely shooken up and turned upside down. And so, we just may not know what tomorrow looks like. Some of the challenges the students face today: academic pressure, social media, financial stress, uncertainty about the future. And so what can we do to help address that? A couple of bullet points that I saw in doing some research is, according to the American Psychological Association, currently more than 60% of college students meet the criteria for mental health related diagnosis. And this is a 50% increase since 2013. And then a working paper published in March by Columbia University found that mental health conditions were the greatest predicator of persistence and credit accumulation among community college students. So obviously mental health is so important to all of our students. Some best practices that I will end on, Mr. Chairman, include regular training for faculty and staff, proactive outreach to students. You know, what can we do to help students before they find themselves in the ditch? Student feedback, what can we do better? Collaborative efforts across all areas of the college. You know, college campuses, university campuses are big, and sometimes information may not be shared across various areas. Consistent support for students. That is incredibly important as well. One thing that we offer on the adult education side is we offer a navigator program. And what I mean by that is navigators are assigned to students. And so if you hadn't shown up for class in a day or two, Wendy, they'll reach out to you. Hey, Wendy, you know, how's it going? What can we do? You want to just check in on you. You know, if we can expand that program beyond just adult ed, that could have potential impact as well. And one program that is offered at Hines Community College is called a Single Stop program. And others may offer it as well, but I'm just mostly familiar with Single Stop. And what Single Stop is it's an office where students go, and they are shared, or counselors look at them, look at their records, their whatnot, and they see what type programs they're eligible for, what services they're eligible for. That includes mental health as well. And so that's just a few best practices that you know, we've identified. And so I want to just conclude my remarks again by thanking y'all for what y'all are doing. You know, the community colleges are here to help in any way, and you know that we are dealing with mental health issues as well on our campuses, much like they are at the K-12 level and the university level. So, Mr. Chairman, with that, I'm happy to answer any questions or comments folks may have.
Thank you. And you mentioned just a couple of things here. You know, the the Navigator program, I know coming out of COVID, in particular in nursing, community colleges are heavily involved in nursing training.
Right.
We did some funding for nurse navigators. Excuse me. The thought there was that, you know, the navigator would come along alongside the student. You make sure they were following through the program, give accountability, much like in our discussions earlier on the school resource officer, and basically an accountability partner.
Right.
Through the K through 12 could be, you know, a school nurse, could be a school resource officer. The navigator seems to be an equivalent to that.
Right.
Are you seeing that there's more need for that, particularly because, you know, as I see the world coming into community college and to graduate and postgraduate work, the kids are changing. You know, they have different personalities. The ones who rotate through our program in our office, they're a little harder to connect with.
Right.
You know, how do you deal as a navigator with kind of the isolation kind of tendency that I think we see in more students who are coming out of high school, and can a navigator be a resource to kind of pull them into other activities that they maybe have not been as involved in?
I think the answer is yes. You know, so much of life is about relationships. And if I'm a navigator and I'm assigned to you, Senator Parker, and I can develop a relationship with you and learn about you and help you navigate college, you know, that's a great thing. And so I think that those type programs can be successful. The problem is those type programs cost money, and, you know, funding is limited, much like everywhere else. And so that's the issue that we oftentimes run into from the navigator perspective. And y'all are to be commended that with the navigator program that y'all adopted 2 years ago for the nursing side. Thank y'all.
So you did see some benefit to that while we had that in place?
I think, yes, sir. I don't have any evidence in front of me, but I can find some outcomes and share it with you.
Very good. I'll open it to questions, Senator Boyd, then Representative Creekmore right after Senator Boyd.
Yeah, Kel, the last statement that you put in here, that this working paper that found that mental health conditions were the greatest predictor of persistence and credit accumulation among community college students, obviously makes this paramount to us making sure that we get this addressed if we want successful community college students. All right, so on that note, let me ask you this. are you aware of any of our community colleges at this point that require mental health training for their faculty and staff?
I don't know if it's required. I know that it's offered on most campuses, but I don't know if it's required. I can find that out for you soon.
Okay, and the continuing theme that we've had really throughout the days is how much are we connected? So my next question is, we know that the Department of Mental Health offers free mental health first aid training in every part of the state. Do we know if they're connected with that community mental health center? That's my next question for you to ask them about that. And then the other question too, with the community mental health centers, again, when they know that there's a crisis, are they connecting that student up with the community mental health center for that crisis intervention? I want to know what that relationship is, because we've got to get the entities that we're all funding working together. I think that's critical in a resource limited state. So those are the questions that I would ask if you kind of work through with that. And then the other thing too is how many of our community colleges are making students aware of apps, applications that they can directly access on their phone? Because I think the stigmas that you bring up exist, particularly even in more of our rural parts of the state. I think those stigmas are a little greater sometimes. So, and then the telemedicine that they're offering, is that through the UMMC program? And do they know the availability of that?
The UMMC program was not mentioned, I don't think, in any of the responses.
Okay.
Outside vendors, but that's another opportunity that we can connect with the medical center. You know, we're all guilty at times of working in our silos and not knowing
Right.
what other options are available. And so those are great points.
Okay. All right. Thank you. I look forward to hearing from you.
One thing about the stigma or the stigma in educating students, one comment that was provided to me by a college was, you know, they'll send emails to students about opportunities, and they'll, on the flat screen TVs in the hallways, you know, September is Suicide Awareness Month. And oftentimes the emails go unread, and the screens you just walk by and don't look at. So.
Yeah. Thank you.
Thank you. And you asked a lot of the questions that I had about the community mental health centers. But two things is, I assume everybody goes through an orientation, even the adult students. And is mental health part of that orientation?
I believe so. If not, it needs to be, because that's an opportunity to have an audience where you have all your incoming freshmen shared, you know, what opportunities are available. I will make.
Exactly. It's a great introduction that there's services out there. And then two, in RA today, I'm not sure, is that just a student that's responsible for?
It is. So each dorm has a director who would be, you know, at the hierarchy of the chain, and then the RAs or the student workers, if you will, who live, they're paid to live in the dorm and sort of head up the hallways, that sort of thing.
Is there training to be an RA or?
I believe there is.
Okay. And is mental health part of that training?
I would think so, but I can confirm.
Okay. Thank you.
You mentioned with the telehealth that they were vendors. So those vendors, are those out-of-state vendors? Do you know?
Yeah, I know one for sure is, and the way those work is the students have a certain number of visits. It's not unlimited. That's just how the contracts are set up.
Oh, so, okay, so my follow-up to that is, if they are out-of-state vendors, then how does that lean to continuity of care and connection with local boots on the ground services if they are in need of immediate care or immediate treatment, or even follow-up treatment,
Yeah.
or something that they need, you know, more in person?
Yeah.
You know, it's easy telehealth, and that's something they can connect to and do, but
Right.
if there's no one here local that they
Right.
can continue that care with, then to me, that's creating a, you know, an immediate thing, but then you're not helping down the road and establishing continuity of
Potential
care.
disconnect
Yes,
after
sir.
that immediate need is addressed. Yeah.
Okay, I'm probably speaking from a little different perspective. I have had 3 kids go through college, and through all of them, the orientation, we sit down in orientation and they tell us about mental health. Oh, if your child needs help, they need to go here. We go through it, and I had one that act, my personal child, it says, Mom, I'm just depressed. I just don't know. It was during COVID. And I said, you got to reach out to somebody. And she did, and she went through and everything worked out great. I had another child, a personal child, she was like, I just don't know, I don't want to be here. And I was like, remember what happened at Welcome Week? And I don't know if it was Welcome Week or Wow Week or whatever. And I would say that when my children went to school, they didn't go to junior college right away, but they did dual credit, but they went to school. It was very important that that first week of school, when they were doing all those fun things, the people on campus, because mom and dad weren't there that week, that people on campus were like, you're gonna hit a bad spot. You gotta reach out. And my kids, the three that have gone through those situations of going through that, they felt the staff and the RAs and the orientation leaders and all of them were there for them. And that's what got them wherever they might need to be, the one that did go through, that did seek some little counseling. She sought counseling. And that was the biggest thing that helped her. She felt like, I'm not the only one. Everybody here in this room is listening to this, and everybody in this room is saying, hey, we're going to hit this spot. We don't know if we're going to hit it in college or after, but we're going to hit this spot. And that was one of the biggest things, because parents knew about it at orientation, and the first week when the kids went back, the staff, as well as those little activities they all did, it was pushed to them, you're going to need it.
Right.
And I think that's one of the biggest things for the kids to understand. And I'm a middle school teacher, but this is my personal experience. The kids need to understand, you got to know to reach out and someone will help you.
Yep.
And I just think those are very important to do as far as when the kids go off to college, because I'm not there with them.
Yep.
Other questions for Kel?
That's okay. Thank you, Mr. Smith, for being with us today. And working at our junior college, at Jones College, we do push mental health at our orientations. We do push our staff and faculty being up to date on all the different things. So thank you all for always pushing that and supporting us in that. Because like she was saying, that we constant throughout the semester, we're pushing different programming, different things that we're having, the health and wellness fairs, to push mental health, because at that age limit, we think that is so important for them.
Thank you.
Thank you, Sarah. Any other questions for Kel? Well, we appreciate you being here and
Thank you all.
offering your perspective from the CJC level. I think we have one more speaker from IHL. We got another PowerPoint that's being handed out here. But finally, we're fortunate to have Dr. Al Rankins, Commissioner of IHL, joining us today. Again, like what we've done, if you would just, again, you don't need much introduction, but, just give us a little background. And, again, the topic of our task force is mental health and its impact on, particularly, I think the young people, and then their transition into IHL and into your arena is key for us to understand. So we look forward to hearing your perspective. So turn the floor over to you.
Well, thank you so much for the opportunity to be here, and thank you for the great work this task force is undertaking and will continue to undertake. I want to start by saying what we've seen in recent years with respect to demand for mental health services. Pre-COVID, our universities were seeing an uptick in the number of students on their campuses with some type of mental health disorder. And in general, our university did not feel like they had the adequate staff to address the demand at that time. Then COVID hit, that spring semester of 2020, and after spring break, the students didn't come back to campus. We switched to online learning, and in the fall, they came back to campus, but their classes were delivered in a combination of in-person and online format, depending on size of the class and the ability to adequately social distance based on the guidance we received from the Department of Health. And currently what we're seeing today is the demand is continuing to increase for services on our campuses. So that's currently where we are. So in preparation for today, to give the task force a snapshot of where we are, we posed 3 questions to our universities. What is your campus doing to address your current mental health needs? What's needed to address the current demand? And what's the status of complying with Senate Bill 2408? I thought that was something that this task force needed to know and something that I wanted to know. And for those who don't know, effective July 1, we're charged with making sure that ID badges for our faculty, staff, and students contain contact information via text, dial, or chant for crisis line 988. So I'll give you an update on that as well. So I'll start with Alcorn State University, and I won't walk through all the information on all the slides because there are going to be some common things. I'll just kind of go through them and point out a couple of points. Alcorn State University has 4 full-time counselors. They have budget lines for 4. They currently have 3 and advertising for the last one, and they operate within the Department of Counseling Services, which provides the first line of services for students that have needs on their campuses. They also make referrals to about 15 local agencies and hospitals as necessary. They also have a counselor that's on call for night and weekend services at their institution. And they offer a variety, you see them here, of educational and outreach services to inform students about what's available, to educate them about recognizing symptoms within themselves and their peers, and most importantly, to encourage students to utilize the services that are available and move past the stigmas that have been mentioned earlier and actually utilize those services. Needs identified were more counselors, more space for treatment, more resources for students to provide outreach activities, and more training. And Alcorn reported they don't print their ID badges in-house, they outsource it, and they're on the way, and they should have them ready before the start of the fall semester. Moving on to Jackson State, you see a similar theme. They provide their services through the Natasha Norman Counseling Center. I remember that young lady and what happened to her at Jackson State because my mother actually taught her in high school. Jackson State identified similar needs. They also specifically talked about they're seeing increase in the number of severe psychiatric cases, and the acuity level is increasing on their campus. And Jackson State as well will be fully compliant before the start of the fall term. Delta State, as with our other smaller institutions, they offer their services through their counseling services center. They have 3 full-time professionals 2 that work year-round, and 1 that works in the fall and spring only and does not work during the summer. They are fully compliant, and they've identified similar needs as other institutions on their campus. You'll find with the smaller institutions, the first line of services is delivered in 1 unit. However, at our larger institutions like Mississippi State, those services may be offered across several units. Mississippi State has 18 full-time mental health professionals, 1 full-time healthcare educator, 1 full-time psychiatric nurse practitioner, and several graduate students and others that help supply services through an array of units across their campus. Mississippi State identified the need for more licensed mental health professionals like other institutions, and the need for more resources for outreach programs. They also identified the need for more inpatient treatment options across the state, as well as the availability of licensed mental health professionals to be able to hire on that campus. And I think that issue was mentioned during the presentation on yesterday. With Mississippi University for Women, similar to what we've seen at the other smaller institutions, they offer services through their counseling center. They make referrals when necessary, and they also utilize telehealth. And they are compliant with Senate Bill 2408. Similar situation with Mississippi Valley State University, and they've identified similar issues that were identified by the other institutions. At the University of Mississippi, looks very similar to Mississippi State University. They have several units that offer various types of services to students. They also refer students out when necessary. They have telehealth options. And they've identified similar needs as the other institutions. But I want to point out that the University of Mississippi, they actually provided us some data on type of numbers that they're seeing. In fiscal year 2024, their University Counseling Center serviced 17,706 scheduled appointments, 467 crisis and walk-in appointments, and answered 1,477 after-hour calls. So at one university, that gives you a snapshot of, the level of services being provided and demand, particularly on our larger campuses. And they are currently compliant with Senate Bill 2408. The University of Southern Mississippi, again, they have several units that deliver services to students. And one thing that Southern Miss pointed out was an increase of demand for services during midterms and finals. And they've made arrangements on their campuses and have things in place to make sure they can provide additional service during what they identify as peak times for service. So I went through those pretty quick because a lot of the information is very similar, but I do want to give you a summary of what we've seen across all 8 of our campuses based on the responses we've received. With respect to mental health services, our universities have campus units that are delivering frontline mental services. These units are staffed with licensed mental health professionals, and all of our universities, to some extent, utilize telemental health as a tool to supplement those face-to-face services. Referrals are made when necessary to local mental health service providers as needed, and mental health outreach programs are provided on all of our campuses. to again encourage utilization of the services and recognizing issues with peers and within themselves. And all of our institutions currently are or will be fully compliant with Senate Bill 2408 by the start of the fall semester. Moving on with additional summary information, the needs highlighted, the needs highlighted in blue are the most prevalent identified across all of our universities. The need for more licensed professional counseling staff and not just having the funds and resources to hire them on their campuses, but actually having a pipeline and the availability to be able to hire from to get them on their campuses. And I think that issue was talked about a little bit in the presentation yesterday afternoon. Uniformly, they talked about the need for more professional development opportunities for staff, and also more outreach and educational programs for students to make them aware of the services provided and encourage utilization. Additionally, more space, more inpatient treatment options, and a centralized state-supported telemental health program. Several of our institutions currently utilize UMC's telehealth program. I think it's called Unite. But I think it just got off the ground on April the 15th. So we have a lot of institutions that have existing partnerships. But I think as that program grows, and I think it's funded with a $750,000 external grant, and they receive more funds, I think we can move more towards a more centralized telehealth system in the state. And one of our institutions mentioned possibility of a state-sponsored loan repayment program for licensed counselors, and I think that's to address the need of their desire and need to recruit and retain more licensed counselors on their campuses. I want to briefly talk about some system-level initiatives. Back in March of 2021, we applied for and were awarded a $240,000 year grant from the governor's office to do a pilot mental health needs assessment, and it was conducted by the medical center. Dr. Nicholas McAfee at the medical center, he headed up that effort, and he subsequently reported the results to the IGL board. As a result of that report, the following year, we did make a request to the legislature for funds to expand, to start and expand services provided and fill in the gaps that were identified in that survey. That request was not funded, but subsequently, the medical center did request grant funds to try to expand telehealth options within our system. I don't want to go into a deep dive of Dr. McAfee's data because it was pretty expansive, but I do want to mention some of his key findings. Anxiety, depression, suicidal ideation, and substance abuse were the top mental health concerns reported in his survey. About half of the respondents indicated plans to reduce class load due to mental health concerns. That's a problem. As with K-12 students, mental health issues affect academic progression. And The third key finding was 29% of the respondents reported receiving some sort of past mental health care. Now, I will tell you that the survey went out to about 16,000 students across the system. The response rate was a little above 11%, so we had about 1,800 students to open the survey and actually complete it fully. So you can have some idea of the numbers we're talking. And I want to mention in 2023, the Center for College Mental Health, in their annual report, it's a national report, anxiety and depression have been the top mental health concerns reported by mental health clinicians over the past 10 years. And if we look at Dr. McAfee's data, anxiety and depression were the top mental health concerns reported by students. And nationally, over the past 10 years, those were the top concerns reported by those individuals who are treating those students. So I will stop there, Mr. Chairman. I want to thank this task force for your time and your attention towards this effort. This is a very serious issue, and I'm very appreciative of this task force looking into it. Over my career in higher education, I've seen a lot of issues involving students. And I've got a story on the positive end where when I was in the classroom teaching, I taught undergrad and graduate courses. I had an undergraduate student who was a great student, who went on and graduated, got in graduate school, and I had him a few years later in graduate school. And he wasn't doing well in my class. And one day after class, he and a line of students had questions about the lecture. And he said, "Dr. Rankins, I don't really understand, this concept. I need some additional help." And I said, "Well, why don't you stand to the side, let me talk to these other students, and I'll talk to you one-on-one." And when all the students left and I had him by myself, I said, what don't you understand? And I said, let me tell you something. These are the same concepts you had when you took my freshman level class. Problem is not you don't understand. Problem is you're drinking too much. And he kind of laughed, "Oh, Dr. Rankins, no. I said, look, let me tell you something. I said, I've been a college student, I've been there. Okay. You're drinking too much." He put his head down and he said, "Dr. Rankins, married now, I got a wife, I'm working and trying to go to school, I got a small kid and it's just rough." I said, "Well, whatever problems you have, the bottom of the bottle, I'm not gonna solve them. You need to get some help." So fast forward years later, he saw something in the news about me and he called the office, wanted to talk to me, and my secretary said, "We got a guy who's a former student. Says he wants to talk to you and congratulate you." I said, "Okay." So I called him and talked, and he has his own business now and doing very well. He said, "Dr. Rankins, I just want to tell you, you saved it." Now, that's on the positive side. I've also seen students with issues, and we try to help them. We work with the parents, and we had a situation where, a student didn't want to take his meds. And it's digressing, and, was at an age where the parents couldn't forcefully do anything to try to intervene and help him. And that student ended up in the justice system. And the worst side of this spectrum is when I get a call from the president to tell me that one of the students committed suicide.
Thank you, Dr. Rankins. And I think always, kind of the personal stories are the reason that probably everybody on this task force does what they do. It's responsibility and volunteering and doing things. And even, just in your role and coming and speaking today and sharing personal stories, it takes a level of dedication and a desire to try to make a difference that I think is exactly why we meet and do these things that we do here. Would you agree that, it seems in our discussions that a lot of the problem with mental health is something that, it starts early, it continues to progress and it develops, and then it, when it reaches the IHL level, it's at a different level of intervention. But it seems in the discussion with both you and Kel that a lot of the problems kind of are already slightly evident when you're interviewing someone to come into the college. Can you tell a difference now in the kids in the interview process at as they're entering, or are they developing more of these mental health issues after they enter college? Or where do you think our intervention needs to be targeted more directly?
Well, I definitely think that we have a lot of situations where kids come to us with issues, so it definitely, the intervention that need to start with us. But I do think you do have some that may develop issues over time. I think the key is to have intervention and resources available from elementary school all the way through their career with us. What we're seeing is, young people today, they deal with different type issues and problems that we have to deal with. I was coming up, if you had a bully you were dealing with, you avoided the bully. With social media, these kids, they can't do that now. So the type of problems and the type of complexities, the complexity of the problems that they're dealing with, they need resources. They need different type resources, and the type of resources that they're needing are changing. And we have to be nimble enough to be able to recognize that we have to change to make sure that we're doing all that we can to make sure that every student is successful at every level. So I do think there is a difference. I think COVID has created some differences or speeded up some differences as well. When I poll institutions, my concern was about learning loss, particularly for those students like my daughter who were locked down, that junior, senior year in high school. How is that going to affect them academically? What the universities are telling me is when they look at grade distribution pre and post-COVID, they don't really see a big difference, but they do see a significant difference in the interaction these students have with their peers and the social aspect. They're seeing big differences there because they tend to be more isolated into themselves. And in my opinion, that's not a good thing either. So, we are seeing some differences.
Right, and one last question from me, and then I'll turn it over to the committee here, is that we talked with Kel about the importance of the navigator in the community college system as someone who, particularly as we did that with the nursing program, as somebody who could identify or come alongside the students and, kind of help them along the way. Who do you think is the equivalent at the IHL level of a navigator within the system who can help identify and find those kids who might be isolated, or find those kids who might be drinking too much, or that kind of thing? And who and how do you get attention on that at the IHL level?
I think on our side, it's not handled through one entity. It's probably over multiple entities, various offices that I talked about at various institutions, but also peer counselors. Because a lot of times students will share things with their peers, not going to share with adults. So peer counselors are used a lot on our campuses to help students stay on track and successfully navigate the challenges of being a college student.
Thank you. Representative Creekmore.
Thank you. I would assume every student declares a major, they have an advisor.
Yes.
Is that throughout IHL? So would that advisor not be that person that could be the navigator and maybe receive some training in mental health first aid, perhaps?
The advisor could be one of those persons because they do meet with them periodically throughout.
Yeah. And that may be something this committee could look at because the advisor should keep them on track through academically and maybe even look at it from a social standpoint. On your loan repayment program for licensed counselor, I assume the licensed counselor is a mental health professional, which is a master's level of education. And that's one of the recommendations that I think we all need to discuss. We've discussed it last year and during the legislature, but not just for public universities, but for people who would stay in the state of Mississippi, because we've heard that from every person's presenting. We don't have enough mental health professionals. So that's something I hope we'll strongly consider. Thank you.
Commissioner, could you get us a copy of the GEAR study, just of their findings? Could y'all send forward that to us? That would be greatly appreciative. The other question that I kind of hear from university professionals living in a hometown is that they see children, kind of back to your question, is they see students that come in that seems that they have less coping skills than they did. And they don't know if this is related to our use of technology, COVID, or multitude of factors. Would that be a statement that you think would apply across the board?
When you say coping, could you be a little more specific?
Coping really, as it applies to a lot of different things, not just to daily decisions, to helicopter parenting, maybe where they haven't had to make those decisions. That they can see a vast difference in students in their ability to manage basic crises, small crises, daily crises for themselves.
Here's why I do see a difference with this generation of students related to coping. I do see a difference when they're told no, or they don't get the grade that they think they should get, okay? Or they feel rejected in some kind of way. I do see a difference in how that is handled, and I think that could be attributed to a lot of reasons. You know, this is not scientific. This is just my personal opinion, but I think it could be a factor of how we are bringing up children now, where I'll give an example. When I played Little League Baseball, there was one MVP. It went to the best player. Now you play when my son played Little League Baseball, everybody got an MVP trophy, regardless of the skill level. So, you know, that may sound a little harsh, but I think those type things contribute to, because at some point these little kids are gonna be adults. They're gonna be in the workforce. They're gonna get an evaluation, and their supervisor's not gonna tell them that they're the best thing since sliced bread. They're gonna be honest with them. And what I see is, you know, too many students not dealing with that type of rejection well. I don't know if that answered your question regarding coping, but
It's just, that's something I've just continuously heard. So I just wanted to see if that was pervasive. So thank you.
That led into my question. I was wondering, we've talked a lot about interventions and things that can be done when we notice things going on with our students at all levels. But is there anything at the IHL that they're considering to be proactive for coping skills so that the students will have the skills that they need, not only in college, but when they go out into the workforce to manage themselves? Because I think those things may need to be taught more now because of the things that we're seeing.
There are a lot of things going on. Someone mentioned orientation. During orientation, they go through sessions on coping and coping skills and how to deal with different situations. And all of our universities offer some type of class in getting adjusted to university life. So there are a lot of proactive things going on to try to get ahead of those issues. And I think the young lady a little while ago gave a great example of what she saw with her kids. And I hope it was at one of our universities. Okay. Requirement for the students. I think some of the classes already are a requirement. I don't think it's a requirement that you participate in orientation. But I think it's certainly something that we can take a look at.
Dr. Name.
Dr. Rankin, thank you. I wanted to follow up on, you'd mentioned like thinking through the role of peer counselors to kind of expand the ecology around a kid's life. Back moons ago when Dr. Bounds was there, I remember I had the privilege to kind of work with the IHL student body presidents to kind of think through mental health plans in their respective campuses. And I'm curious, is that group still active? Back then, this is pre-COVID, to your point earlier, pre-COVID, that was their number one issue. If that group is still active, I'm wondering if, because, they're transitioning to adulthood too and giving them more voice into what's going to work for them, be it peer counselors, professional, is there a way that we could maybe work with those representatives of the various student body as a collective to pull ideas of how we might run at them in a more effective way?
Sure, that group is still active. They meet during the fall and spring monthly. Laura, can you raise your hand? She works directly with that group. So get with her and she can talk to you about maybe getting on their agenda and seeing if you can get some things moving.
Any other questions? Well, thank you, Dr. Rankins, for being here today. And again, we got a good cross section in the day from, starting from kind of K through 12 all the way through IHL. So your perspective is very good, and we will, put that into our discussions as we continue with this task force. So thank you for joining us today.
Thank you for the opportunity.
So with that, we'll move to just some more kind of housekeeping here. First of all, like I mentioned yesterday, your takeaways that you're developing from this, I would encourage us to let's compile those takeaways, and if you would send those to Jennifer or Deborah in peer, and if they could maybe put those together into just kind of a working document of just suggestions or takeaways from each of you and what you kind of found important or what you'd like to learn more about. I anticipate the next meetings to still be, some degree of information gathering, but we may consider, instead of maybe 6 speakers, we may do, 4 or 5, and then have just a time at the end where we can kind of discuss some of the things that we think are what we need to develop a little bit more. The challenge that we have is an October 1st reporting date, and we all have busy schedules. So I anticipate maybe 3 more times we might meet, maybe 2.5. But we have to do this kind of quickly and efficiently so that we can prepare something that we're all comfortable with and get feedback on. So with that in mind, I've got a list of a number of conflict dates. I know last time we talked about school beginning on the 1st. So a date that I've looked at as a possibility would be August 7th and 8th. Similar times, beginning Wednesday at perhaps 2 o'clock, picking up again on that Thursday morning at 8 a.m. Does anyone have any major problem with that date and time? Dr. Baker? Okay. Okay. I figure we'll have. Yeah, so it's just going to be hard to, the week before is one thing, then the next week's not available. The week after that's got something. So we're just, we'll go with that date for right now and then adjust and, zoom in, as necessary. So, and also when you do send the information in, I think, some of the things we've identified kind of, I think, put us on a direction of what we might want to learn more information about, and so when you do have your high points that you send in, also send in additional speakers who you think could expound upon those directions and the information that we've gathered here, so, and that way we can, kind of further point our efforts, towards coming up with some potential solutions that can be of help to the state. So, other than that, Jennifer and Deborah, did we have any other housekeeping that we needed to do in preparation? Does that give you a pretty good idea of where we need to go? Yeah, so if you would email that, and if there are no further questions, I think we're going to end pretty close to what we expected right at 11. So motion to adjourn. So moved.